So we all know that since the time inception, way back, man has learned to argue and discuss. The debate has always been regarded as a hallmark of human intellect. And what essentially seen in debate is at the end of the debate, we come to some conclusion and some agreement, except a few never-ended debate on a happy married man. So coming to my debate, the scenario under debate is well assumed that the other eye is absolutely normal. It's a unilateral cataract. And RLE or phakic IOL, which were debated in the first round, is not as an option of consideration. So if you'll see the etiology of unilateral cataract, what you will see most often is congenital syndrome associated or the pediatric cataract. In younger adult, the common reason for unilateral cataract is trauma. And a significant proportion of cases, what we see as a metabolic or idiopathic, though the reason is not known, but the entity is not uncommon. So I will try to prove why I choose monofocal over multifocal in this subset of patients. So the first in line is pediatric cataract. If you will see the literature, there are enough evidence that the cataract, where unilateral cataract is there, the eye is behaving very strange. I mean, all the parameter of the eye, looking at the cornea, the axial length, and the steepness of the eye, the smaller diameter of the cornea, in many study has been seen. So the consensus for getting a good IOL number with biometry is very challenging even for monofocal, let alone the multifocal. So we do not know about the right number of, right power of the lens for these tender eyes. So if you look at the condition post-operatively, it is most weird. I mean, the shift in the eye, progressive shift in the eye, is not let to get you resolute on the monofocal power itself. So leaving alone the multifocal. If you will put the multifocal or trifocal in such eyes, you will imagine the kind of vision the patient will get with the residual huge refraction what the patient will have. So coming to the traumatic cataract. Traumatic cataract is always enigmatic. I mean, the challenge is the complete assessment of the eye is always there. And then you will bound to have some or the other intraoperative surprises, wherein you will have some unpredictable things in the intraoperative condition, like the zonular weakness are there, and which will lead to the decentration of the lens. And we all know that compromise in the multifocal or trifocal when you are having decentration. And the post-operative consideration is also very important because the patient may have subtle injury at the retina, at the canalicular system, which will lead to the glaucoma post-operatively or reduce contrast of vision with the subtle retinal injury. So in these traumatic unilateral cases also, I will choose monofocal over multifocal, looking at all these conditions. I'll keep at least one option of monofocal against multifocal. Now the most challenging is the last is the idiopathic condition, where of course in most of the cases we will also go for, I will also choose trifocal, but there are instances in idiopathic condition also where I will go for monofocal, like psychological profile of the patient. If patient is always landing into the kind of patient who will keep on comparing the two eyes after the surgeries, you know that in younger patients, whatever you do, there will be some reduction in the contrast in multifocal eye, and we all know with the science that the light transmission is never 100% in multifocal. So matching with the other eye, the optical profile is always challenging. So you are having two options. Either you counsel your patient too much, but at the same time you'll have to assess your patient that patient's psychological profile is conducive for. So to conclude, I again say that the entire case assessment is very important to give any option to the patient. We need to assess not only eye but also the psychological profile. The long-term implication of the eye when you are considering a particular subset of the eye where unilateral cataract is there is very important. We need to choose the best fit, not just going for the technology, not just going for the price, or not just going for the industry push. The patient is ultimately yours and you need to justify the science for that particular scenario. and give the best to the patient. Thank you.
I'll just add one line that you should rise in the occasion. You should go for the technologies which has come in the market. And if you are satisfied with the technology, you should go with it. So you yourself has deferred that idiopathic cases, you go for trifocal. And why you are debating then?
So that's
So
not
in case
idiopathic, it was total subset of unilateral cataract where I will choose this.
The spiral lenses has come.
Let
the
us
trifocal has
let us
come.
take the expert opinion.
Yes.
And our expert is none other than Dr. Hatem Amar. He is the board member of Egypt Ophthalmological Society, and he is a faculty in Sohaz University, Egypt. Over to you.
Good afternoon, everybody. I am really happy to be with you in India. It's the first time to me in Delhi. Very nice city in this extraordinary meeting with very large number of halls, sittings. Thanks for everyone who invited me here. It's a great pleasure to be in this session and to comment on these presentations. They asked me to comment. Actually, this is a point of debate. 15
Dr. Sujoy.
15 years ago, there is no point of debate. Only never implant multifocal IOL in unilateral case. Even those patients who is pseudophakic and one eye with monofocal, never implant the other with multifocal IOL. The old one, restore and resume, you may not see these forms. It is because the company say, I am official speaker for Alcon and Johnson. The company say, the patient will suppose that the monofocal is much more better than the multifocal. Nowadays, multifocal, the quality of multifocal, whether it is a trifocal or EDOF, are gaining much refinement with much more better results. So there is a total difference between adults and the children. Adults, nowadays, we implant one side only. Those patients who implanted pseudophakia with monofocal and come for the other eye, if you give him trifocal or EDOF, they will get very happy and ask for the reverse, to explant the first monofocal and let him be binocularly trifocal or EDOF. Okay? Why? Because quality of IOL is improved. In the same time, the need for spectacle and the dependence increased. It is something like cosmetic surgery for ladies and filling lips, and it is increasing to gain popularity in the world. So people are looking for spectacle independence. But on the contrary, for children, I think it is extremely risky to implant multifocal in unilateral. Because quality of multifocal is good on emmetropia. It is not forgiving for any type of ametropia. That's why never implant more than one diopter of astigmatism. Never implant in those who are changing refraction. As Dr. Dera said, always unilateral cataract in children is with a change in pathological eye, abnormal eye, with a progressive change in refraction. So patient may be happy for 1 year, 2 years, but later on, you need to explant this IOL. Can you afford this every 2 to 3 years to explant IOL implant another one? A really challenging situation. If I think, for my experience, I will not implant premium IOL for children less than 12 years old. Above 12, maybe, because you may do LASIK, corneal refractive surgery for fine adjustment. But for young age, 6 years or 5 years, I don't think will solve the problem. You will create much problem because the quality of vision may be amblyogenic if it is ametropia.
Dr. Hatem, you are a very good expert panel. So we want to take up our last debate, and I would request you to become an expert panel in the last discussion also, please.
Thank you.
You did, and surprisingly, our expert panel didn't come, and Dr. Hatem is a great addition, replacement, I will say.